Good morning. This is James Cooley with the Health Policy and Clinical Services Division of the Texas Health and Human Services Commission. This is another one of our webinars on quality improvement, in this case related to better management of superutilizer populations. Very pleased to present the Primary Care Innovation Center in the Houston-Harris County region. They're a nonprofit whose mission is to improve quality and reduce costs through coordination of care through superutilizers. We first learned of this project about almost a year ago and followed their work and came down to visit with them late last year and enjoyed it a great deal. The presenters are Dr. David Buck, the director and founder, and Kawal Mahata, the IT solutions architect. And I will, without further ado, kick it over to them. Please type questions in the chat box, and the handout has the slides. And let me, any questions, if there's anything I'm not hearing something or whatever, just also put that into the chat or questions. And with that, I'm going to take it over to the presenters. Thank you.
Thanks, Mr. Cooley and the State of Texas Health and Human Services team for making this possible, and the team at PCIC who helped put this together. Let's start with a story. How many of you have met a superutilizer? This is one story of a superutilizer, Curtis, before and after the PCIC intervention. Before, he had weekly visits to the ER related to his diabetes. He had unmet mental health challenges, no primary care provider, and was referred to PCIC after an amputation and multiple preventable admissions. After, his ER visits decreased dramatically. His care was coordinated between primary care providers and specialists, and he was approved for benefits, perhaps most importantly, housing. And he reconnected with family and social service resources to build relationships. In his own words, I still have the problems here and there, but not as severe. Sometimes being a patient is just a number and strictly about money, but you all really care. And you can see him in the center of the screen here with the certificate of appreciation. So the agenda for today is we'll discuss superutilization nationally, locally, and characteristics that define this work. We will share the structure of the Patient Care Intervention Center, or PCIC, and our essential partnerships. We will highlight the specifics of our intervention, highlight one of our most exciting new partnerships, and review barriers and enablers to care. At the end, we will have 15 minutes for Q&A. An introduction to the superutilizer problem. Of the $2.8 trillion spent on healthcare, $1.4 trillion, or 50%, is attributed to only 5% of the population nationally. This population is known by the ironic term superutilizers. We're going to focus on this impact in Texas and focus on the top 1% that consume 20 to 24% of the cost nationally and 24% in Texas. This slide demonstrates that in Texas, 1% of the population consumes 24% of the cost, as you can see on the left graphic. This is 50% higher than the national figures. In Harris County, the top 1%, rather than consume $90,000, they consume $134,000 each. Or the top 1%, or 6,000 superutilizers, consumed $806 million in 2011. Why are these figures higher in Harris County and in Texas? Well, certainly it has to do with that Texas is one of the most populous states and has the largest barrier to healthcare access in terms of insurance, but it also may reflect the lower expenditures in social infrastructure that have been shown to drive the medicalization of social problems like homelessness. But this is a broader issue. Who are these superutilizers? Individuals whose complex physical, behavioral, and social needs are not well met through the current fragmented health system. As a result, people bounce from emergency room to emergency room with costly, chaotic, and ineffective care. This metaphor is courtesy of Mr. James Cooley. You can see the broken chair and how difficult it would be if one leg was broken, much less all four. When someone is struggling with one or more broken legs, they are wobbly at best, but superutilizers often suffer from all broken legs. Focusing on one broken leg won't get it upright. This is where PCIC and our decades of experience with this population comes in handy. We have worked with the homeless and incarcerated since the early 1980s and learned the tiniest of efforts can identify barriers, coordinate care, and have a profound impact. For example, we demonstrated a 64% reduction in rearrest rates of inmates with serious mental illness only by assuring continuity of care on their day of discharge. So, PCIC's mission is to improve quality, reduce costs through coordination of care for the most costly and vulnerable. This workflow shows that prospective clients are referred to the program up in the upper left red square on the visual. They're referred, and if they meet inclusion and exclusion criteria, which we can discuss in the Q&A if desired, but in short, the inclusion criteria is 4 or more admissions in a calendar year or 10 or more ER visits with 2 or more chronic conditions. Once referred, PCIC reviews the case and decides if the patient is a good fit. The patient is assigned to a coordination team composed of a registered nurse, a social worker, and 2 firefighters. The care coordination team will meet the patient in the hospital or at home or on the street for engagement and enrollment to the program. Working with the patient and care coordination team will identify the routes of utilization, set goals to modify the superuser behavior, and define trigger events that will help track progress. We track utilization of the system through admissions, claims, and ER visits, and track costs through visual analytic tools or dashboards that can provide an at-a-glance view of outcome indicators at the provider level, at the system level, and at the community level. This slide shows our current list of stakeholders with whom we have contracts and information sharing agreements. 2 early adopters were the Houston Fire Department, who contributed 2 full-time equivalents that serve on our team, and Community Health Choice, a local health plan that we have formed a paid super user management contract with. Our sustainability model began with grant support in years 1 and 2. As grant dollars leveled out, the organization is focusing on the development of additional revenue streams for diversity and sustainability. The CHC model is set up as a superutilizer care management contract based on pay for performance with shared cost savings for both parties. The third bullet is our current hospital plan model that's paid on a pay-per-visit for care coordination and a shared percentage of cost savings at the end. And our sustainability plan also includes the development of customized dashboards for each of the institutions. These dashboards are being developed at multiple levels. We have built capacity to formalize and make uploads and downloads systematic and secure. At this time, I'd like to introduce Kalal Mahata, our informatics architect, who will share with us the database and analytics side of our work, and more importantly, the role of dashboards in care coordination.
Thank you, Dr. So in the next few slides, we're going to take a look at data sharing and data analytics, which is the first and essential step in our care coordination process.
Or just mute it.
So over the period of a year and a half, we have set up data sharing contracts with a number of institutions and have received data dumps from them. These are diverse data sets containing both clinical PHI data as well as non-clinical data. For example, as you can see, jail data, data that we received from the Houston Police Department, which contained arrest, crime statistics, juvenile arrest data, as well as data from the Homeless Management Information System Services, which was data about service usage by the homeless population in the Houston area. Having a diverse data set helps us not only in identifying superutilizer patients, but also in presenting a more complete story and timeline for a patient. So here what we're going to do is take a quick look at the process flow and look at the life cycle of data and the process flow and interaction between data and the intervention process. So the workflow starts with receiving data from stakeholders in a secure manner. This data goes through a cleanup process where we eliminate and clean up bad data and migrate it into the PCIC data store. Once the data is initialized into the PCIC data store, it goes through a data blending process where records are linked in two ways. One, linking to existing records from previous data dumps from the same stakeholder. And two, more importantly, linking records to other data sets from other stakeholders. The second method of linking enables us to perform overlap analyses between systems. The next step is eligibility and patient identification. In this step, we build dashboards that help us identify superutilizers in the system by filtering the data by using different measures. For example, we break down the data by age, by cost, number of ER visits or number of admissions, the location of the patient, etc. This is our initial filter criteria. The next step is client selection and enrollment. Identified superutilizers go through a more rigorous selection process where we look at detailed inclusion and exclusion criteria, for example, diagnoses. In addition to patient identification from big data, which is done through our overlap analysis, we also have a referral program where stakeholders can refer superutilizers already identified by them to PCIC. Once we have enrolled patients, we track them through the intervention process and perform pre- and post-intervention analysis on their progress. So in this slide, we're going to take a look at the different kind of data points that we collect. So over 400 different data points are recorded and tracked during the intervention period. This slide will show us the different ways in which we track the progress of a client. So there, we start off with their medical history that's recorded into the system, a care plan with shared goals are identified with the patient, Their progress is measured using scoring mechanisms like the DLA-20 form, which is the Daily Living Activities Functional Assessment Score, or quality of life measure, the ACE score, which is the Adverse Childhood Experiences, the ECOMAP, which we use to document and visualize the social and personal relationships of the patient, and the root cause analysis. This is not only a way to track progress, but also serves as a visual to the provider and the care coordination team to quickly communicate the complex clinical picture. In addition, we also track outcomes by performing a pre- and post-intervention analysis, looking at not only these different scoring mechanisms, but also at cost, visit counts to the healthcare system. Now we're going to take outputs from the patient selection process to the intervention process to post-graduation and follow-up are provided to our stakeholders in a visual manner using dashboards. And these are completely web-based dashboards. These dashboards are built at different levels, from the detailed patient-specific view to the high-level institution view. Our goal is to look at the data at a community level to help better understand the needs of the entire community, which is the substance of population health. We're now going to take a look at selecting superutilizer patients from a dashboard. This is a de-identified dashboard that was created for Community Health Choice. And I've broken down the entire dashboard into 2 slides to be able to give us a more detailed look into it. In this first slide, we're looking at a high-level visual of all clients. We use the filter criteria that are on the top of the page to filter the visuals and narrow down the list of patients. So for example, you can see we can filter down by county and city on the top, followed by total cost per patient. We usually set that to about $130,000 per patient, given that that's the average cost in Texas. Using these filters will cause all of the visuals below them to automatically be updated. Looking at the visuals from left to right on the first row, we see a demographic distribution of the patients followed by an age distribution. The third graph displays each patient's total cost as a horizontal bar. On the second row, the first chart shows us the total cost breakdown by admission, which is shown in red, and ER visits shown in blue. The second chart identifies the most common diagnosis in the selected population group, and the third chart shows a breakdown of admissions versus ER costs for each patient. On the next slide, here we're seeing on the first row, first chart, each patient's visit is shown as a vertical bar, and the shade of the color, the number of unique institutions they visited. The darker that red color, higher the number of institutions. We can see that on an average for this population, they visited an average of 14 or 15 visits in total per year. The second visual on the right, on the first row still, is a heat map chart, which shows each square as a patient, with the size signifying the number of visits and the color the number of chronic conditions. Now, bigger the size of the square, more the number of visits for the patient, and darker the color, more the number of chronic conditions. On the second row, the first visual shows the institutions that had the most number of visits for superutilizers. The second visual shows a geomap of the utilization over time for the selected patients. This second visual becomes a lot more useful when we select a specific patient, which we're going to see in the next 2 visualizations. So here, this is the exact same set of charts we saw in that first, on the first slide, except we've filtered it out for one single patient. All the visuals are now filtered out for that selected patients. Their location, their total cost, as well as their cost broken down by their ER visits and admissions, as well as their diagnosis as shown in the bubble chart. A detailed view of the data can also be viewed at any time from these visuals. For example, here we see all the diagnoses for that one single patient. So on this slide, again, the 4 visuals have been filtered out for that one patient. The first visual shows us that the patient has a total of 42 visits. On the second row, first chart, we see all the different institutions that one patient visited, each bar representing a single institution and the number of times the patient went there. And the last visual on the second row shows us the patient utilization over time on a map of all the different institutions they visited. And as we progress that arrow on the map, it will show us every month which institutions they went to and how many visits they had there. These visuals help us hone in on the top 5 to 7 super utilizers that we could then enroll into the intervention program with CHC. This is just one dashboard that we took a brief look at. Each institution's dashboard is different depending on the kind of data. For example, dashboards from hospital data are very different from a data set like this, which is an insurance provider. At this point, I'd like to hand it over to Dr. Buck to continue on with the next set of slides.
Thank you. So now we're going to talk about the Care Coordination and Intervention Program. These are shared steps required for a PCIS client to graduate. You can see in the slide Path to Graduation. You can look at this from either the PCIS or community perspective, or as if you were the client and knowing this is what you have to do to graduate. And it's a part of a team effort. We'll now explore the specific steps for the person we started with, Mr. Curtis, and what components were necessary for his graduation. First, you can see he was referred by one of the Healthcare for the Homeless programs. An eco map, a DLA 20, and medication reconciliation was performed. Goals were identified, which are shared goals, not started by the team, but rather in the words of the patient to help us be clear of what and align with what the patient's goals are. Control diabetes, stable housing, and a secure income. Then establish PCP and specialists with working with him with a PCP, his endocrinologist, and psychiatrist. Close diabetic monitoring, SSI application were a part of his initial intervention. We want to improve the quality of life, and the DLA was improved by 39%. His SSI was approved, and he obtained housing. Blood glucose levels normalized. Psych symptoms improved. Housing and income secured, and he had an in-home care provider. Phase 2 results show that 28 clients had met the inclusion criteria. For those, we successfully managed 13. On average, their EMS transports decreased by 51%. Their improved function improved by an average of 34%. Overall, there was a decrease in 52% for the total cost at the Harris Health System. Admissions went from 5 to 0. ER visits decreased by 50%. Interestingly, though, you can see under OP or outpatient visits that the outpatient visits decreased. We thought they would increase, but the cost for those visits increased. This suggests these clients are having fewer visits but are better managed overall. Care coordination may be alerting the clinician to the many illnesses that require care, not just the two conditions which we refer to as comorbidity. Often it's 5 or 10 conditions requiring care, which can be overwhelming, of course, to the patient, but also the provider, especially if this is their first session. So what motivated Community Health Choice to join in this effort with PCIC? Here's what they said: that it was important in achieving their community's overarching goals. Engaging members and providers were important in improving the overall health. They wanted to participate in the community through a collaborative project and improve access to health care for low-income families. They wanted to be improving cost-effectiveness of care and promote health through effective and efficient resource utilization. So what have we developed together so far? Well, we've identified 7 clients through dashboards. We've recruited, enrolled, and started working with 2 of their clients. CHC's hopes include the appropriate use of services for the patient to be able to manage their own care and to be able to communicate with service providers when they become challenged again. For Mr. Curtis, this was actually when he re-engaged care, when he re-engaged a connection with his family. And he realized when they treated him badly that he first blamed himself like he did for most of his life, and then realized that this was part of what his problems stemmed from and could address it more directly. They also wanted to identify, and did identify, what helps these clients overcome their barriers or community barriers through enablers. Here's a quote from Richard Lee, CFO at Community Health Choice. PEACE's comprehensive coordination of care model provides patients with better outcomes through root cause analyses, frequent contacts, and social supports. The service cost per patient is lower than ER cost, and the return on investment can be reasonably calculated. Community Health Choice is excited to be a partner with PEACE's on the Medicaid population and may consider other lines of business. So, lessons learned, barriers and enablers. Sharing data is the first and essential step to care coordination and is used to help drive the intervention. Overlap analyses help provide a view of the superutilizer community overall, not just one institution. One characteristic of superutilizers is that they use multiple institutions. Individual hospital superutilizer programs can only see their own data, preventing them from seeing the whole picture of a superutilizer client and how best to care for them at a root cause level. These represent the barriers at the client and system levels that have negatively impacted care. At the client level, communication challenges, which could represent trust. Transportation challenges. We had multiple challenges where the van was supposed to pick them up, the city Medicaid van for Metro, but was consistently late and they kept missing their appointments. This was tough when a patient did the fasting 1 day in advance bowel prep, only to 2 times be turned away. No primary care provider, limited and unreliable transportation, no support network, low education and reading level, and perhaps most importantly, loneliness. At a system level, these barriers are different. The providers that don't accept Medicaid, no appointments were available, too many referrals, no accountability, and no coordination among institutions. We use a root cause analysis with our clients to help show their medical problems, but these are just the tip of the iceberg. Social problems, substance abuse, serious mental illness often go unaddressed. By combining the RCA, the last slide, with this eco map, we form a better understanding, identifying social support structures that are barriers or enablers for them. Here's a view of what they were when they first enrolled. You can see many of the red issues or challenges here. 70% are challenges. But as you can see, these challenges midway through the PIECES intervention, the challenges are transformed to being resources. What used to be major barriers are in fact building relationships that become a positive and source of a resource over time. At graduation, we expect 80% of their challenges to be seen as a source of strength. Some we can't change, such as you can see here, prison, or maybe an abusive brother-in-law. So this is the Q&A part of our presentation, and we open the floor to questions.
And this is James jumping back in on the line. As befits a moderator, I'm going to throw a couple of quick things out. One, and this is not so much a question, but something that we're doing as an agency and that we're going to look at this project first, is we realize that we've never really looked at superutilizer projects to see their impact on Medicaid. So this is one we're going to see if we can actually look at some of their cases and using our Medicaid data, validate some of the results they're seeing. And this is something we're pretty excited about. The one question I want to throw out first, because I think it's very important, we see projects that seem to be working out there in the community, whether they're hospital projects or waiver projects or projects like this done by a nonprofit. But the issue that we see over and over and again is sustainability. Projects start up as grant funded or waiver or they're pilots, but making that transition from a startup to something that is mainstreamed into healthcare funding, a way to keep the doors open on projects that do appear to save money and improve care. But that challenge of having them go from startup into it and seeing, because you are engaged with a health plan, if you could elaborate on that, the efforts that you're undertaking with a health plan, which thank you to them, on this move to long-term sustainability and mainstreaming this into just the way that we do business.
Well, I would say that it's key that we learn and build a relationship, and I think that's why it's taken a while, in that we need to be able to understand what their needs and concerns are, and they need to be able to articulate what they want us to do or what they want the change to look like. For example, with national reforms, the the tracking of readmission rates made that something that was understood throughout the community. And we could help speak that language by showing the institution that the readmission rates, actually we did a study about 10 years ago showing readmission rates among the homeless at one of the public health facilities were 10 times greater among homeless than in domicile at a public health indigent care facility. And so trying to learn what their language and needs are really can help drive the conversation. And part of the shared savings packages and things like that help align these interests of theirs and make sure through dashboards that we can deliver on what they want to see.
And given that there are so many other questions that have come in, I'm going to turn it back to you. If you can simply, on the questions that have come in, read them out and then answer. Take them in whichever order you think works best.
So one of the questions was about handouts. I think it was part of the handout section on the GoToWebinar application, but I think we can send that out as well in a follow-up email.
One was pieces cost to coordinate.
So is there a cost to use?
Is there a cost to use PCIC? So there's no cost of the hospitals to refer to us, but there's a cost to coordinate the care. So we started off all grant supported and doing everything without any cost, and now we're moving into a contract model. But people can refer to us different patients via phone or via email. Another question was how to assist undocumented immigrants who are superutilizers. We really didn't pay attention to payment source from the beginning. This happened about a year into the project. So we work with the county hospital district and help coordinate care of the super user regardless of their funding status. So this has not been an issue. How long do we follow patients? We follow them 6 months after discharge, and we try to follow them all the way through the following year after graduation from our program. Will this data be analyzed retrospectively for all PCIS partners? The answer to that depends on the partners. If they want the data to be analyzed, we are more than happy to perform the analytics. But it's driven really by what each of our partners would like. For example, the Homeless Management Information System wanted analytics to look at services at their institution and how it varied within EMS or emergency medical runs to try to identify people that they were serving. So that was a retrospective to try to help identify people. Some want it just kind of more on a live time to identify people that come into the ER. Another question was, how many readmissions per year qualify a patient for being a super user? Great question. So that can be determined by the institution, but PCIS has the minimum of 4 admissions a year per patient is the minimum threshold, or 10 emergency room visits. I don't think that's a question. trying to identify other questions here.
Oh. Yeah, there was a note about the visuals. The graphic visuals on the slides were not displaying very well. We can always do a separate one-on-one demo of certain dashboards and go through them. They're obviously going to be much nicer when we do a more interactive demonstration, when we bring up the web page and we can click through everything and see everything refresh real time. And the visuals will be a lot clearer. So please feel free to reach out to us if you'd want to do a one-on-one demonstration of the system. We'd be happy to do that.
But as you can probably see, the dashboards are best when they're customized to each site. For example, you could do an overlap analysis with multiple institutions that could help drive what the overlap analysis can provide a dashboard, say, if an institution wanted to know the number of people they were seeing and how much the patient was using the surrounding institution. So in other words, maybe they weren't a super utilizer to the surrounding hospitals, but they still used more than half of their visits outside of that one institution. Or if they wanted to see the total diagnoses or maybe total cost, they could see that this patient could be coming to them soon because they kind of hospital shop around, and it's only a matter of time based on how superutilization works that they'll be coming to their program.
So we have another question. What is the maximum number of members that your team can effectively manage?
So what we're doing now is in our current scaling, we do 15 at a time or 60 to 90 in a year. We hope at the end of the year to be scaling up to double that amount.
So we have a question that says, what is your engagement and reach strategy? This was from Karen. We find it difficult to find people once they leave the ER or hospitals, as they may have no phone numbers.
That's a great question and relates to a lot of the challenges with the homeless. So what we try to do is with the cooperating institutions, when someone hits their ER, if we can use a live ADT feed that tells us someone hit the ER, we can try to go out to their hospital immediately and engage them. Because you're right, that's the quickest and easiest way to engage someone in care. If that's not possible, then we rely on phones, we rely on the fire department, because they're kind of the grounds, the feet on the ground, and can often identify people that we may not see otherwise.
So we have a question here about the platform that we use. Can you share the type of platform that you use to build superutilizer dashboards? There's a bunch of different softwares we use. So the main ones are Tableau. We use another software called Alteryx. We use R, which is an analytics software programming language. In addition to that, we've kind of customized it for our needs, so we do quite a bit of in-house software development as well to build our dashboards. There's another question. What have you learned about the initial selection criteria using 4+ inpatients or 10+ ED visits and 2+ chronic conditions after reviewing the case in detail?
I'd say it varies from person to person, what we've learned. Often, as you saw earlier, we look at dashboards to better understand some of the precipitants and barriers to care, but we learn the most once we begin to engage the client and to do the RCA, do the root cause analysis, do the eco map, and begin to see what the main issues are for them.
I was going to add, as far as the initial patients we're seeing right now, I think that we're way above that criteria of 4+ inpatients and 10+ ED visits. We're more in the 30 to 40 ED visits, and certainly over 10 inpatient visits. And then their chronic conditions, most of them are a lot more, certainly a lot more than 2 chronic conditions.
So as you can see from previous slides, we are only able to engage even right around 50% of the people that are identified. That's one of the big challenges. And I think that's where a whole community-wide approach is so important, so that a patient can't be in a certain hospital that doesn't participate, and then you don't even realize that opportunity to engage them in care.
There's a question about funding. As you mentioned, funding from Community Health Choice. What are other current funding sources, and what do you envision for the future?
This is Brian Bolton with PCIC. That's a good question, and one that we've asked ourselves this year. There's a slide in the handouts that you'll see that talks about our sustainability model. The first year, year 1 and year 2, we've been dependent on grant funding. But as grant dollars level out going into the 3rd year, we're focusing on developing super utilizer management contracts with insurance providers and with the top 1% super utilizers at hospital systems. And then thirdly, we're able to develop dashboards and IT infrastructure for organizations as well to help them identify their super utilizers.
The next question, do you work with transitions care coordinators in various hospitals to identify these utilizers? And our work started with the homeless many years ago, and that was one of the first questions we would get. And it is very difficult to engage the actual care coordinator or the care coordinating teams for the individual clients. I'd often call, ask to speak to them, and they were out or they were not available that day. But one of the things we're doing with CHC and one of our other partners is that the institution identifies a specific care coordinator to work with us directly and to be a part of our team, not as a subcontract, but literally to work with them as part of the team, so that when the patient is stabilized, they then go back to their care coordination teams, learning what we did about the different barriers and enablers to care. Does PCIC provide intervention or just provide data? Great question. The answer is both. We collect all the data from the different institutions, and then we provide the intervention that we spoke of, where we go to the hospital, street, to the house, and engage the client and do those steps, including if you look at the graduation, path to graduation, it shows the steps of what we do.
How many readmissions per year qualify a patient as a super utilizer?
So what we have is the minimum criteria as 4 hospitalizations in a year. We don't look at readmission specifically. So we're just trying to target the sickest people, and typically these people are readmitted not once or twice, but many times, and often for the same thing every visit. So we really just look at the threshold is so low. There are so many people that meet this criteria. We try to look at the ones that we can have the most impact. What is the role of the MCO? Great question. So if we look at CHC as kind of the model or gold standard, their role has been to let us know what they needed and to meet with us. They shared data with us to drive dashboards, and those dashboards then drove interventions, which ultimately led to a contract with them. Another question is, what steps did you take to engage facilities and outpatient providers to better collaborate services? Do you want to, Dr. Fulch? So one of the steps we did is we've had stakeholder meetings. We have them quarterly, and we tell all the stakeholders what we're doing, and we meet individually with them to try to engage them in care. The ER docs, interestingly, the ER nurses, they'll often reach out directly to us, where we have met with some of the hospital leadership team, and there is much care that goes on to develop a contract. The provider teams in the ER are hungry to try to get help from us, and so we've worked at both levels. Are you able to share model agreements or contracts that have helped you develop this problem or this program? And the answer there is CHC has been generous, but I would have to ask them because it's a contract, so we'd have to get permission. But any of our contracts, we would be willing to see if they would share. We've been very grateful to our partners in Camden, New Jersey that have shared many of their contracts with us as well. Another question is back to how to identify a superutilizer. Your answer was more than 10 ED visits. Does this include ED visits that result in an admission? And the answer is yes. Another question is, you mentioned that you can engage only 50% of the superutilizers and that only 13 of the initial 28 showed a decreased utilization. So what that reflects is we had as our target goal to graduate that number, and it took the 28 to engage them in order to get to yield that number of graduates. So the people that didn't graduate, the bigger challenge are people with the lowest resources, whether that's educationally, whether that's illness. That's really the key. And homeless people are less likely to graduate because their resources are so impaired. If you look at the slide we've put up in the phase 2 results, you can see the 28 total clients were enrolled, but only 13 were successfully managed. Many people, quote, fired us. They quit, and some came back after quitting and became a successful graduate.
We couldn't reach some of the patients.
Yeah, we could not reach a large number of the patients at all. Even through our homeless providers, all the feet we have on the ground, some people were very difficult to even engage at all. Another question, it's a great question. What is the level of training of your clinical staff that provides the interventions? Well, on the outset, we have an MSW or Masters in Social Work and an RN team. We also have the firefighters who are trained in advanced life support. We also are starting what's called psychologically informed environments, or PIEs, something that's worked very well in other workplaces, particularly with the seriously mentally ill. And we're doing an every other week session with our staff to try to build cognitive behavioral therapy skills, the dialectical behavioral therapy, and action, acceptance commitment therapy. Those modalities have been successful in really building the resources of a team. Another question was, are you interested in going to the Valley, Dallas, or San Antonio? Of course. Please just reach out to us. Another question is, will the recording of this presentation be made available? I think that's a question for the state, but they are going to provide that, I believe, the link at the end of this presentation.
I'll jump in on that one. What we do is we do try to post links to our presentations and the slides. There will be, we have to go through our webmaster, but we'll turn in the request. It'll take a few days, but as the presenters noted earlier, the slides, a PDF of the slides can go out to the full attendee list. And yes, our intention is to post a rebroadcast link. But again, it will take a little bit of time to get it posted to our website.
Another question is, what is the nurse-patient ratio? And we have a slide from right here called the workflow, where you can see we have an RN and an MSW that oversees the EMS teams, and we don't have on here the community health workers that are also being hired now to work with the teams. So you can see there's really one RN and one MSW per 15 clients. And our goal is, certainly next year, is to have 2 of these teams. So there'd be 30 patients at one time. Does PCIC accept referrals only after a hospital stay? And no, we manage the care of people that are just high emergency room users. So it's either, if you look in this workflow on the left of your screen, it says 4 admissions to the hospital per year or 10 or more ER visits. Another is, are you collaborating with a housing program? That's a great question. Yes. In fact, that is the program that's called Homeless Management Information System. We work with them and the local Healthcare for the Homeless Houston to help with obtaining housing. Another question is, how do you get the patients to want to participate in the program? Great question. I think that's where years of working with the homeless help. We have to try to understand what makes a difference for them. And so we'll often start the conversation of, how is this working for you? Is there something you'd like to be different? And how could we help you? And the patients are often very skeptical of trusting us. As you could see through the adverse childhood experiences, many of these people share the common experience of horrible abuse. And so to trust us, or anyone else for that matter, would be really ill-advised. And so we often tell them, please don't trust us. Let us know when you think we're making a mistake. We want to try to help you reach your goals. And so that's a technique we've used with the homeless for years, and it's been helpful with the super utilizer group as well.
All right, we're coming up on, well, it's 11 o'clock right now. I would say this is the highest number of questions we've ever had come in on one of our webinars. There will be follow-up to any questions that we didn't get to. The presenters can have the ability to follow up. Please do follow up directly with the presenters. If you can take it to the slide with the information email. And just really thank you so much for doing this, and look forward to continuing to work with you ourselves, and hope that among those that listen to the webinar that some of you will follow up. And with that, we look forward to having you on again for our continuing series on quality improvement. And again, thanks again to PCIC.